Thanks, Bob. So I'm going to talk a little bit about neovascular glaucoma. So these are the most common causes of neovascular glaucoma in descending order. Diabetes is the most common cause. CRVO, carotid occlusive disease, CRAO, rarely. But chronic inflammation and a variety of retinal disease can also cause neovascular glaucoma. And as mentioned, what you have is a rapid onset of symptoms, a red, painful eye, nausea and vomiting, increased intraocular pressure, and usually the neovascularization of the iris initially is visible at the pupillary margin, and then later on crosses the iris into the angle. By the time they start to look like this, they're in a lot of trouble, or like this, even more trouble. And historically, these eyes have been doomed. This is neovascularization of the angle. The advent of Avastin for the treatment of not just wet macular degeneration, but for neovascular glaucoma has been a very significant thing. We can now selectively eliminate the cause of the neovascular factor. So we actually at the DMG Eye Institute did a study evaluating this. I thought this was the best name for any clinical trial ever, and this is the generic name for Avastin. So, and I won't go over all the details of this. Just basically, we did a retrospective chart review of all the neovascular glaucoma patients, and we compared the characteristics and outcomes of the patients treated by traditional treatments versus those who utilized Avastin as a primary or adjunctive treatment for neovascular glaucoma. Basically, the long story short is that Avastin allowed for conventional trabeculectomy or the expression or tube shunts over cyclodestructive procedures. The Avastin treated group showed a greater IOP reduction. They experienced near total elimination of all neovascularization of the iris and the angle. There were no short-term side effects, systemic or ocular, reported from the avascular injection in this series. So really more studies need to be done, and we're just now finally seeing in the literature more and more come up about Avastin and neovascular glaucoma. This is an eye with neovascular glaucoma. You can, it's hard to see with these lights, but there are some vessels here. This is not as florid as the other cases, but you can see the iris angiogram showing areas of leakage here. This is the same eye after Avastin a couple weeks later. You can tell it's the same eye because that same wedge lens defect is there. And you do not see those areas of leakage on the iris angiogram. So typically what you do then, this is how you take care of these folks, is that they come into your office and either you or a retina colleague needs to first, if you can, get some Avastin in the eye. This is especially helpful if you have no view to begin with. If you inject Avastin, you can bring them back in a couple days, and usually the corneal edema has cleared enough for you to laser, not always, but very often. So it adds a whole new dimension to the treatment of neovascular glaucoma. There were many patients with neovascular glaucoma in the past where, if we couldn't PRP, I would have to take them for CPC or something right away just to get their pressure down from 60. So typically, if you can wait, you want to wait because you want the inflammation to die down. So I typically wait at least a week, but preferably even more. But you don't want to wait too long because eventually that Avastin is going to wear off. Hopefully, the effect of your PRP will be more enduring. But if the pressure doesn't go down, and you get full resolution of the neovascularization, but the pressure doesn't go down, you need to go to surgery. And I'm in the process of gathering data on a large series of neovascular patients in which I've placed this implant. Post-op issues in neovascular glaucoma, you need to, there are certainly more high maintenance. You need to consider 5-fluorouracil injections if you see early blood failure, early laser suture lysis, and have the patient do digital massage to keep things going. You know, thinking about injecting Avastin intraoperatively, my thinking is I don't want to make another hole in the conjunctiva, so I just make a slightly larger conjunctiva incision and inject there. Thank you.